Well, thank you all for coming today. I have the pleasure of introducing Atri, who's a longtime friend and probably, in my opinion, probably the foremost clinician and researcher in Alzheimer's research today. I'm going to try to boil down his CV, which was 40 pages long. It took me an hour to read. He has a PhD in mathematics from UCLA. He did his training at UCSF for medical school, and then he also did a Harvard MIT clinical investigation translational research in medicine degree. He did his residency at the MGH, did a fellowship in computational and cognitive neuroscience at Boston University. From 2004 to 15, he ran the Mass General Memory Disorders Unit. They wooed him away to San Francisco with a $20 million endowed chair by Ray Dolby in 2015. Most recently, he's the chair of the best practice guidelines for Alzheimer's clinical care in the United States. He's a reviewer for over 35 journals. He's a PI in over 20 Alzheimer's clinical trials and has been global PI on about 7 of them. He's published 48 articles, 12 book chapters. But more importantly, I think he's a social humanitarian, and he's the kind, he's really, his goal is the betterment of humankind. He's applied that to Alzheimer's disease, and he's the kind of human who can do it. There was a book that describes some of his journey called The Social Structure of Scientific Revolutions by Thomas Kuhn, who examined what happened whenever there was a scientific revolution. And in 2008, he published probably a seminal article showing that the combination of memantine, an NMDA receptor modulator, and a cholinesterase inhibitor can delay the progression of Alzheimer's at all levels of functional severity by 33 to 60%, which means that we can achieve a 10-year delay in the progression of Alzheimer's disease if we detect early before function is impaired. And this article was in 2008, I mentioned. It's absolutely consistent with my clinical experience using that combined therapy over the past 15 years. And it has been summarily ignored. You see in the press every day there's no treatment for Alzheimer's disease. This is factually incorrect. He's demonstrated it. I've seen it in thousands of patients, measuring it individually. And if this had been several centuries ago, he would have been stretched on the rack, drawn and quartered, and then burned at the stake. But in the 21st century, we simply choose to ignore scientific discoveries until the amount of evidence is overwhelming that it's true. I think we're beginning to get close, but we're still hearing no effective treatment in the popular literature. So I don't want to take any more time away, and I'd like to introduce Atri.
Thanks, Rod. Thank you very much, Rod. I'm very humbled. I'm just a person who takes care of patients and families with Alzheimer's disease. I teach, and we don't have cures, but we have hope, and we have more than that. We have data, and we have process. So these are my disclosures. I'm not part of any speakers bureau. I'll apologize up front. It'll be like drinking water from a fire hose, the amount of stuff I'll show you. You're welcome to have my slides. These are my slides. I'll send a PDF to you, so please talk to Stacy, and I'll send them to you. I'm involved in advising companies and clinical trials, and I always start with this quote. to ground us. Human beings are members of a whole in creation of one essence and soul. If one member is afflicted with pain, other members uneasy will remain. If you have no sympathy for human pain, the name of human you cannot retain. This is as true now as it was all that time ago in ancient Iran, Persia. We don't cure this disease. It affects a whole population, but we have to do better. And what it comes down to is I'm going to talk to you about abnormal proteins and PET scans and p-values, but it comes down to people. What can we do on the margin for the individual? And honestly, I can tell you we can make a difference. Age and disease progresses no matter what we do, even with medicines. But even now, we have treatments that help us. And the reason I think, Rod, people always say we have no treatments is that we want to mobilize somehow money and for new treatments. But I think then we ignore who we have now. So it turns out to be, in some ways, nihilism and dementiaism propagates that, which you and I agree is very, very wrong. So if you look at this, I would like you to think what you think of this by the end of this talk. As a scientist, I can tell you that maybe we could say this is 50% by volume, or it's 50 mLs plus or minus 0.5 mLs of H2O in 100 cc glass. But ultimately, at the end, I'll ask you the same question. As an overview, we know that the prevalence and cost of dementia are going to increase. People are getting older. Big risk factor is age. And it happens all over the world. This is not just a US phenomenon. China hasn't figured it out. India hasn't figured it out. And as the silver tsunami is coming, we're going to be overwhelmed, unfortunately, with dementia, and most of it due to Alzheimer's disease. It turns out that the process is incredibly dynamic and complex. We're learning more and more how much that is. It occurs over decades, and this is part of the new thinking. Many roads lead to that dementia phenotype. So it turns out when somebody comes to you and they have a syndrome, signs and symptoms, we really don't know what's causing that disease. And it turns out that many different pathologies end up interacting. And people can have very heterogeneous symptoms. And particularly older individuals have many different pathologies. And that's one of the reasons probably we've been having a hard time curing this disease. No new treatments have been approved since 2002, 2003. And we've had many failed clinical trials, and I've been involved in almost all of them. I don't care what it is. If it's licking this table, if you can scientifically show it, you can show down the risks and benefits in a placebo-controlled way or in another way, that I'm for it. Unfortunately, everything from the pharmaceuticals to vitamins, all those things I've been involved in. In the dementia stage, we haven't been able to succeed since 2003. So there's not going to be a magic bullet just to cure people. We are making progress in understanding the pathophysiology and using biomarkers. So what are biomarkers? So I apologize if this is too simple for some people and a little bit more advanced for other folks. But basically, there are things we can measure that are in the pathway that give us an idea whether you have increased risk. And then allow us in some ways to maybe use it to treat people and see what our treatments are doing. Broadly, I'm going to give you a review of evaluation and care, what we think are the best practices. Ultimately, what we have now are called symptomatic medications. So when Dr. Shankar was talking about cholinesterase inhibitors, memantine, we consider those quote-unquote symptomatic. We don't know what they're doing to the disease process, but what I can tell you, the evidence is pretty strong from grade 1 randomized double-blind placebo-controlled trials from 6 months to 24 months that you can actually change the disease course in the sense that what you see can be changed in supporting function, behavior, and cognitive processing. And ultimately, the expectation really isn't that people aren't going to decline. It's that you're going to slow down this clinical progression. And it really depends on the individual. And when you diagnose them, how much that is. Again, you also have to balance risk and benefits on the individual basis, and you have to have a really interdisciplinary team to give this care. And if you do, you can decide at the end whether these things are meaningful or not. We do understand there's a very, very long preclinical phase, and I'll tell you what that means, where people are at risk, right? And the brain is fighting. And we have a 10, 15-year period now, we understand, where people have symptoms. And this gives us an opportunity to intervene during that time. I'll broadly talk about risk reduction and where we are in clinical trials right now. No person is an island, entire of itself. Any person's death diminishes me because I'm involved in mankind, and therefore never sent to know for whom the bell tolls for thee. Very few of us are going to be spared, whether it was Ronald Reagan or Margaret Thatcher or Dudley Moore or Robin Williams. This affects not just the person, but the whole community around them. And this could be a picture of any, grandfather sitting there, and even this poor dog can get affected in some ways by the situation. But I can tell you, this is my dad, and we took care of him at home for over 10 years. He passed away almost 2 years ago now. I grew up near here, so I actually went and saw his grave this morning. And I'm wearing his cufflinks today. And I never, I can tell you, this is the hardest thing I've done in my life. I took care of him when I was already a dementia specialist. When I was in graduate school, I took care of my aunt, who was like a mother to me. And I can tell you that it affected my kids. They were involved as caregivers, and my wife, and so it takes a whole community, and it's not easy. All right, wait just a dang minute here. We forgot the cattle. So unfortunately, this may be a little late, and it turns out that early detection is really, really important for a number of reasons. It turns out that we actually have a lot of opportunity early on to minimize harm, to shore up support systems, to give people education when their abilities are at the highest levels. When we lose a function, it is really hard to gain it back in the brain. But if we can actually detect things early on and support that function, both by behavioral ways, by sleep, by nutrition, by stress reduction, by medications, it actually leads to better care and reduced costs. So it turns out actually there's a lot of harm to society. At every stage, a patient with dementia and Alzheimer's disease costs 3 times as much. And guess what? In primary practices, it turns out that 15% of people take about 80% of the resources and time. If you look at those people who are above 65, at least half to 2/3 of them actually have cognitive impairment. So when you look at costs, before people get the diagnosis, what happens the 3 years before that? Costs are going up. People are going to the emergency department. They are not taking their medicines correctly. They overdose, they underdose. Their sugars are too high, too low. Their heart failure goes out of whack. It's really not their medical conditions, it's the brain not being able to keep up and manage. So nobody wakes up one morning and says, gosh, this morning I'm demented. Yesterday I was normal, right? So it turns out that in 2011, we finally changed the criteria, and we actually broke it down more like in 3 stages in some ways. But the idea really is that it's insidious. It happens symptoms occur over time. And when people look back, it's actually usually years while people have had symptoms before they actually are diagnosed. And once they actually have symptoms, it still takes almost a year to 2 years for most people to get diagnosed. And data shows that actually almost anywhere from 30% to half the people never get the proper diagnosis. So people end up in nursing homes, demented, but actually they've never had the diagnosis and the correct treatments, which is really, really bad. It's not just inefficient, I think it's morally, ethically wrong. So it gradually occurs over months and years, unless it gets suddenly exposed. So someone comes to the emergency department, they have a urine infection or a pneumonia, and they're completely delirious. Or they've had their hip done, and now they are delirious because of the medications and other things. That's a stress test that they lost. So it means that they were vulnerable, and something happened, and those folks are at higher risk. And of course, over time, it gets worse. One of the things that changed is the idea that like Alzheimer's is just short-term memory. So we changed the criteria so that you could have 2 different kinds of syndromes. You could have the amnestic syndrome, where memory gets affected predominantly first, right? Short-term memory. Now what happened 30 years ago? That can be great. My dad could recite poems until the very end, and yet he didn't really know where he was, what time was, what he ate, etc. But then there are other syndromes, and I see these folks very often because I take care of patients who are both early and young. And it could be language dysfunction. It could be visuospatial dysfunction, not recognizing things that are in front of them. And this is very, very common. Executive function, planning, judgment, reasoning. And this is why, actually, telemarketers are so good at taking advantage of older folks. It's not just the memory, it's also the judgment. So our understanding now is that, before we used to actually diagnose people in the dementia stage. when actually cognition was impaired and behavior and function were very, very impaired to the point where people needed some support. But really, people go through a continuum of abnormalities. And the idea is that in Alzheimer's disease, probably many roads lead to a risk state. What's that risk state? All these neurodegenerative conditions now involve abnormal proteins that we have in our brains and bodies. Somehow they get processed the wrong way, they become a bit toxic, and we can't get rid of them. And sort of the garbage system of the brain doesn't work as well, and they accumulate. And one of them is this amyloid protein. So we can actually, before, used to say, oh, well, we need autopsies to think about that, to diagnose the amyloid protein, amyloid plaques. Well, guess what? We don't need that anymore. We actually have approved PET scans that can see it while people are alive. We could actually use spinal fluid to actually see if people have the abnormal proteins. Years before people have symptoms, years before it becomes abnormal. The data shows that if you take about 170-something-year-olds that are walking around, you test them, and they test normally, within the normal range. Okay? Do you remember that mocha that was in the news this week or last week? So they're scoring normally, 29, 30, etc. Guess what? Of those 170-something-year-olds, 30 of them actually have abnormal proteins. So already the proteins are going up. The question is, why is it some people can really walk around with a head full of amyloid and resist it for longer and other people can't? What are the other modifiable things that could occur here? So then after that, what happens is the synapses, the connections between brains, start to malfunction. For years and years, these proteins, the amyloid proteins, are going around and they're synaptotoxic. We can actually see that in PET scans that use glucose and look at metabolism of the brain, how the brain is idling and using energy. We can see it in other ways also. Then ultimately the thought is that somehow this other protein that's inside cells is very important in supporting nutrients going up and down cells, and for the structure called tau, the tangles occur. And once tangles occur, it's like fire. It spreads through the brain. So the way I think about it is amyloid is sort of like toxic kindling. It's around, it's toxic, but once you start getting those tangles, it's like fire spreading. So the idea is, gosh, even if you suck this out really, really early, you may not be able to put the fire out, or the building's already damaged. Because what happens, we get people here at this stage. That's very, very tough. And of course, after the tangles, what happens is we have shrinkage and cell loss and death that we can see on MRIs and other ways of seeing that, okay? So the idea really is that the new criteria says, you know what, there's an at-risk state, which some people call preclinical Alzheimer's disease. It basically says, you know what, you're functioning, you have no kind of impairment, although you may have subjective complaints. Gosh, I'm not as efficient as I was. But you're testing normally. No functional impairment, but we have biomarker evidence that there's something wrong. So the PET scan could be off, okay, or the spinal fluid could be off. Guess what? This is a very big group now that for the next 10, 15 years, we're studying to figure out if we somehow give them a combination of medicines, can we prevent and slow down the emergence of Alzheimer's dementia? Just like the cardiologists did, right? So many, many years ago, the question really was, right? Gosh, is cholesterol good for you, bad for you? I'll take questions at the end. Question, is cholesterol good for you, bad for you? What kind? What if we take it down? Will we hurt people? Well, guess what? We're at that stage now. And I can tell you, oncologists are really ahead of us too. So we want to get there at some point. So then what they call this MCI stage or prodromal AD, where there's actually some kind of changes and impairment. So you can complain, I've got a complaint that maybe my memory or thinking has changed. We do a test, based on your age and education, you're scoring lower than you should. But generally, people at this stage are compensating. They're doing things less efficiently in other ways, but they're getting stuff done for the most part. And then ultimately the dementia stage, where people need more support. And the dementia stage isn't, oh gosh, I forgot my children. No, that's the really the later stages. But it could be actually a stage where they can't get the tax papers together. They can't plan trips as well as much. So they're actually requiring some help for instrumental, more complex activities of daily living. So very quickly, and I'll tell you the reason I'm going fast is that I'm the director of this Harvard dementia course. It's 4 days, 4 days long. We do it at end of May, June. We start at 8:30. We usually go to 9 o'clock at night. 30 hours of CME. I'm trying to distill 2/3 of that course in 50 minutes here for you guys. So, this is why you can have my slides. But the risk factors, so we have just like a whole lecture just on this stuff. Being older is one of them. Anything that's bad for the brain as far as the blood vessels, okay? This ApoE4 genotype is a risk gene. You'll hear more about it a little bit later. People who have 2 copies of that are about 15 times more likely to have Alzheimer's disease, and when they do, it happens earlier. If you have 1 copy of it, it's about maybe 6 to 8 years earlier, and your risk is about 4 times higher, but it's not 100% that you're going to get it. But then there's these deterministic genes that are very, very rare that some families have, that if you get a copy, if your dad has it, let's say you have a 50-50 chance of getting it, then at a specific time, usually in your 50s or so, then people become demented. And this is another group that's being studied. But ultimately, amyloid, that protein, if it's accumulating in your brain, that's a big risk factor. You can lie about your age and things like that, but you can't change it. But certainly we can modify some of these things, including what we do for our blood vessels. So the idea was that there's this very neat progression between amyloid, then inflammation, then tangles, then neurochemical changes and brain shrinkage. But it turns out that it's actually more complex. Vascular disease is involved. There are very few things in life that are binary, like pregnant, not pregnant, dead, not dead, right? And we get those wrong sometimes. And as you get older, people have vascular disease in their brain and Alzheimer's disease. And they have this whole host of synergistic things that happen. Inflammation in the brain from various causes, vascular changes, and ultimately what we see is neurochemical changes in dementia. And we've been trying to hit things at this very, very last stage just with chemicals. It's not going to work in that stage. We have to be smarter, measure things better, and do it earlier. This is a relatively recent study that shows that basically by the time people get into the probable Alzheimer's disease criteria, you can see actually about 80% or more of them have Alzheimer's pathology, but very few of them have just clean Alzheimer's pathology. Most people have several pathologies, of which vascular disease is the most common. So, talking about best practices, what's our approach? Well, the first approach is, guess what? You have to detect it. You can't give care to somebody unless you can diagnose somebody and evaluate them. So the radar has to be up. If there are symptoms that the patient's having, if a care partner is complaining of it, if you are seeing things in your practice that are making you wonder, why is this person not managing well, then you have to have a high suspicion and try to do an evaluation. When you do that, the first thing is there a clinical syndrome? What is it? So we're not coming up with a diagnosis at this stage. We're just saying, is there a problem? Okay, is this normal aging? Is it not? So you have to actually talk to the patient, talk to the family member, get a history, and do some kind of at least brief cognitive testing. Then the question is, okay, if there is a syndrome, what kind of syndrome is it? Is it mostly memory? Is it executive function and language? Is it mild cognitive impairment? Is it dementia stage? Are there any other accompanying clinical medical features and risk factors? So behaviors. Guess what? 3 to 5 years before people get diagnosed with dementia, what are the most common things that occur? Anxiety, depressive symptoms, sleep problems. About half the people, or at least a third to half, end up getting on a medicine for anxiety or depression. Because people recognize those symptoms, they don't realize that these neurochemical changes are probably a harbinger of neurodegeneration. How much medication is involved? Drugs, alcohol, sleep, apnea, and the family history. Once you've determined that there is a syndrome, then you go down and try to think about what is the biological disease or diseases. So what kind of lab tests can I get to rule in and rule out those things? So that is a process. So what do we do in clinical practice? So really, you end up identifying a clinical syndrome, and when there's amyloid and tau involved, we call that Alzheimer's disease. But it's much more complex than that. So I won't belabor this, but there are many things that you have to look into when you think about Alzheimer's and dementia. Cognition is one of them, so language, memory, executive function, but daily function, behavior, mood, staging. And so there are many, many instruments that you could use, and Dr. Schenkel here has actually developed a really, really nice instrument that has really, really high accuracy. that he uses the MCI screen. And then there's other things, including caregiver burden has to be evaluated. Then we think about what do you send as a first level. People used to call these reversible causes of dementia. Tell you what, they're not reversible. They're contributory. Older people have thyroid dysfunction oftentimes, or vitamin B12 dysfunction, or they may have an inflammatory condition. Guess what? You treat those things, you get cognition back. You get some time back and function back. So this is a suggestion, for example, as a first level for some people. Then the question becomes, what do you do for imaging, right? Your knee gets hurt, you go to an orthopedic surgeon, they usually will get a MRI of your knee. This is a condition that is very, very serious. It deserves one neuroimaging study that's very, very good, and MRI is the best thing to do. Why? It shows you atrophy, shrinkage. It shows you white matter burden, the cerebrovascular burden. It looks at microhemorrhages. About 15 to 20% of patients with Alzheimer's disease have little dots of hemorrhages that you won't see on CAT scans. They've leaked a little blood, they're like little bruises. The blood's gone, but the iron's left over. Guess what? Those people will bleed again and bleed again and bleed again. So if you give them if you're giving them blood thinners, watch out. That's what happened to the Prime Minister of Israel, Ariel Sharon. He had a little stroke. He went in. They put him on blood thinners. They sent him to the Sinai Desert to recuperate before they were going to close the little heart opening he had. But he had had a whole bunch of microhemorrhages before. They saw evidence for it, and unfortunately, he bled before that happened, and he had a massive hemorrhage. He was brain dead for about 8 years. So you can see shrinkage, particularly in these areas, the medial temporal lobe, the hippocampus. You can see white matter changes, telling you really that the vascular disease is contributing, and these black spots are microhemorrhages. And these are actually routinely done now. So this is a routine study, gradient echo and susceptibility weighted images that's done now by radiologists. Then if you are not convinced or you don't know what the syndrome is, my best advice to you is find a neuropsychologist that is very good at this stuff and can actually take time to do the history and put things on norms, and particularly in people who have high function, who are very bright to begin with. It turns out people who are very bright, if they were scoring in the 90th percentile and now they're scoring in the 50th percentile, you may think that's normal. But guess what? It's not normal for them. And they see changes, and family may see changes when they're at that level. So neuropsych allows you to distinguish all these different things, tell you what are the specific weaknesses, what are the strengths, and actually give you recommendations about how to compensate at home. The other things that we can do that are low tier, and these should really be done by a specialist, are in cases where, again, the diagnosis is not confident, the Medicare allows for people to get a PET scan for glucose. Please don't order it on everybody. It'll bankrupt us. We don't need a PET scan on everybody. And it turns out, and I'll show you the picture, people with a classic Alzheimer's pattern have temporal and parietal hypometabolism, lower metabolism. Then you can actually do spinal fluid, and you say, oh my gosh, that is so tough, spinal fluid. This is actually part of the standard diagnosis in many countries in Europe. Scandinavian countries, France, people don't feel like they're diagnosed until they get spinal fluid, showing them, you know what, you've got the abnormal amyloid and tau. We don't do it as much here. I'll do it in patients who have early onset dementia or as part of clinical trials. I just did one 2 days ago. Whoops. And then, of course, we have amyloid PET, which is available but not paid for by insurance. And Medicare is studying to see under what conditions it should be paid for. We just did a study, everybody, including Dr. Schenkel here, where 18,000 people across the country got these PET scans. And the idea is, will it change diagnosis, management, and save costs? And of course, there's some rare things that occur that sometimes you'll have to send stuff for, but routinely we don't send RPR. These tests are really done at second, third, fourth tier if a specialist still feels like there's some uncertainty about the diagnosis or some comorbid conditions, including sleep studies, which sometimes have to be done because it's very prevalent to have issues. This is the PET scan I told you about in Alzheimer's disease versus frontotemporal dementia. In Alzheimer's disease, you have hypermetabolism in the temporal and parietal regions. In frontotemporal dementia, typically it's in the frontal regions. This is only helpful if it's early on. Later on, when people are at the very last stages, everyone looks about the same because everything is destroyed. So this only helps early on. This is the amyloid imaging tracers. These three are available. And here, red is bad, which means the more of this you have in your cortex, in your gray matter. I call this 50 shades of gray. So this is actually what comes out. And the idea is you're not supposed to have this blurring between the white matter and the gray matter. So this is considered positive. Okay. And again, we consider it positive, but remember, it's a continuum. It is a continuum. So what if you have amyloid in your brain or your spinal fluid is abnormal? Okay? Guess what? If you're normal and basically in your 70s and you have abnormal fluid, abnormal profile, your risk of going into having dementia over about 5 years is relatively lower, about 5 to 10%. If you have the abnormal protein, you start off normal. Over the next 4 or 5 years, your risk is more like 70%. And if you're already symptomatic, that is really, really high. So people who are pretty symptomatic, right, they don't have the dementia stage but have abnormal proteins, their rate of progressing to dementia stages is about 90%. So prognostically, we can tell people that. Okay. So let's do a quick review of care and management. The way I see it, it's a chair that requires all its legs. If you only have one leg, it's going to fall over. So the first one, as you know, no diagnosis is no care. So people get underdiagnosed and undertreated. That's really justice denied for us. So the first stage is really accurate awareness of diagnosis. The second stage is really psychoeducation for the family members and the patient. What to expect, how to communicate, what are the strengths and the weaknesses of folks. And here is where a care manager is very important. Social workers are very important. The Alzheimer's support groups, Alzheimer's Association, Alzheimer's Orange County, very, very important. And it takes time and effort to do this. It's very, very important. Then the next step is pharmacological treatments. So the first thing I do is I take the patient and I max out all the meds, right? No, the first thing I do is actually take the meds away. People have drifted over months and years for every symptom they've had. I feel dizzy, I can't sleep. They're getting medicines, they're put in to sleep at night, then they're agitated, they can't wake up. You give them medicine to wake them up, they become aggressive and agitated. They have a list that is this long, and many of those medicines are not good for the brain. So that's the first thing I do. And I look like a hero because I gain some function and cognition back. So that Tylenol PM at night, the PM part, beware, Benadryl, diphenhydramine, bad for the brain. So that's what I do. Then, depending on the stage, we put people on medications and then judiciously use others. But ultimately, the biggest thing is having this alliance with the patient and the care partner. If you don't have that, the rubber is not going to hit the road. I can come up with a beautiful care plan using mathematics, and it's not going to work if the patient is still at home taking their own medicines, right? I had to run downstairs to make sure my dad wasn't taking extra stuff because he was very bright. He didn't have memory, but he was very bright, and so he would squirrel stuff away. So you really have to come up with really, it's almost like doing stand-up. You have to figure out very quickly how to navigate in the individual situation. So what are our main goals? Without treatment, a caricature says people decline like this. Guess what? This is a straight line. No one's a straight line. It's actually more wavy. It's up and down. But generally, what we know, age and disease in this condition causes you to decline. How much? Guess what? Even over 6 months. I'll show you that data. This is an insidious but aggressive disease. Once people are diagnosed, the expectation is that over 6 months they'll decline. I'll show you data for that. So if you get people stabilized or even better over 6 months to a year, that's a win for us. At this point, on the margin, that's a win. So basically, our medicines basically do this. On average, people do get like this, but not everybody. Some people just kind of go like this. Some people go like that. And over time, we kind of see in the long term, we see that slow progression. What we're looking for are medicines that may not have the symptomatic effect, But together with the symptoms medicines in the future, we can give earlier, and we can modify things that hopefully we can get much more disease arrest. But that's many, many years away. So I won't belabor this. There are two different kinds of medicines that we have. They're all generically available now. One is cholinesterase inhibitors, one's memantine. One works on acetylcholine, which primes the pump right now for you guys to stay alert. And at night it goes down. You ate, you're going to get drowsy, your acetylcholine levels go down. But if I raise my voice, your acetylcholine levels go up. You get more excited. And it helps processing and attention in the brain. It's not specific to memory, okay? And this NMDA antagonist works on a different system, and together they actually are at least additive. Then we have a whole bunch of things that people get off-label, right? So people who, the family is at their wit's end, they call, and sometimes they get on antipsychotic or antidepressants and other things. I can tell you I've been involved in all these trials. Unfortunately, at the dementia stage, even though there's epidemiological evidence that it may help people possibly years earlier on, some of them, at the dementia stage, not working. And actually, the ginkgo didn't work even before that. So you have to be very, very careful if you're going to reach for some of these medicines, including antipsychotics. I'll tell you why. And of course, there's these things called medical foods or whatever, and they have very, very low efficacy. And I don't think the data supports their use, personally. So what's the expectation? The expectation basically is that over 6 to 12 months or more, you're going to improve or stabilize folks. In the long term, the idea is I tell people, and I show them the graphs, and I say, you will decline. I don't know when. We all do, but it's going to be slower. And this is the level 1 evidence from randomized, double-blind, placebo-controlled trials. There's dozens of studies, okay? I will focus mostly on the combination, and what I'll tell you about vitamin E is that in the dementia stage, there have been 2 large, randomized, double-blind, placebo-controlled trials, each of them going up to 3 years, that show pretty much the same thing, about a 20% less decline if you take high-dose vitamin E in function. Not that much effect in cognition, but function. And did my dad take it? Absolutely he did. You don't give it if people have a bleeding diathesis, because it's a bit of a blood thinner. So this is the caricature of what happens generally over 6 months. Over 6 months, generally in mild AD, there's a placebo effect when people come into clinical trials, and then they decline. But with the medicines, on average, we get something like this: cognition, function, behavior, or global severity. Tend to be that function's harder to measure, so that tends to be lower, but cognition generally gets a pretty good boost. This is data. I'll show you some data. This is over 1 year. This is the projected placebo. Over years and years, this is what you would project people, how they would decline. Guess what? People came in the study, they got placebo, they declined, just like that. What if the group actually didn't get placebo and got a cholinesterase inhibitor? Boom, on average. What would you predict of this group if they continued on placebo? You predict that. Now, this is called delayed start. They were given the medicine. They got better. They never caught up to the other team, the other group. So really the idea is the benefit is the area between these 2 curves. The benefit that you get from treating earlier is that between those. And notice again, on average, people are going to decline, even with placebo, over 6 months. This is actually, that was rivastigmine, this is galantamine. Another delayed start, real data showing you exactly the same thing. What other data do we have? In England, they took these medicines away. They had people and they randomly took them away. Guess what happened after a year? Crash. Within months, people crashed on average, and over a year, there was much more people who ended up in the nursing home than people who continued the medicines or got an additional medicine. So now we know better. Okay, so very quickly, this is a study we published a few years ago that included 1,400 patients. It was a combination of a number of different trials. The idea was, instead of defining a win at the end, let's actually, for every time point in between, take the points, the area between, and say, you know what, let's see what the difference is if you give people medicines, not just here at 6 months, but over the whole course. The message really is this, is that if they got placebo, they're going to decline. If they got 1 medicine, they're going to decline. If they got 2 medicines, they do better. How much better? About that much better compared to placebo. Okay, that's over 6 months. And And then that's cognition. This one is function. This is behavior. This is overall severity, and this is all of them. So basically, when you give a combination, over 6 months, you're getting about 300 to 400% boost when you consider everything. Does it make people completely undemented? It doesn't. Does that bring their short-term memory back if it's devastated? It doesn't. But we can actually measure it. This is not voodoo. We can actually measure it. Here I have to teach you very quickly, you already know about this stuff, about something called the effect size. When I tell you there's a 3-point difference in ADAS-Cog, even if you're a dementologist, you may not quite know what that means. But one thing you all should know is what was called an effect size. It's a measure, basically. When someone gives you a treatment versus a placebo, you take the difference, the average difference between the groups, and you divide it by their standard deviation. So that puts everybody on the same metric. So what does that mean? Well, the person who developed the Cohen's D said, you know what? This is what it means. If you have basically 16-year-old and 15-year-old girls that are standing up here on two different sides, the difference between their heights has a Cohen's D is pretty small, 0.2. It's barely visible at all between the naked eye. If there are 18-year-old girls standing there and 15-year-old girls standing here, between the two groups, the difference in height is about a 0.5. It's called a medium-sized effect size. And 18-year-old and 13-year-old is a large effect size. Drugs in Europe, to be approved, they have to have an effect size of about 0.2. Okay? Now that I've told you that, here's another study we published a few years ago that basically shows the effect size over 6 months for combination therapies, no matter how you look at it, function, cognition, is about 0.2 to 0.4, small to medium. What happens over time, though? This is the study that Rod was, Dr. Schenkel was alluding to. Well, we did this study at Mass General, and we basically had people coming in every 6 months. And basically, if you start in the mild to moderate stage, and this is true at every stage, if you get one drug, which is cholinesterase versus no treatment, the effect sizes go up over 1 year to about here, but then they slow down a little bit unless you give the combination. The combination does much better. How much better? Well, basically this much better. This is a cognitive scale, this is a functional scale. What you notice is over time, over a year or two, the effect sizes go from small to medium to almost large. What is the problem? If you got the diagnosis right, what happens over 4 years? Everyone should decline. That's the problem. That's why when people come and they say to you, I don't see a difference after a year, that's actually a win. So this is just something that shows that costs go up based on dependence. So these are medical care costs, these are non-medical costs. As a function of dependency, whether you can handle money, all the way down to where you're incontinent, every time you're at a different stage, the costs go up. So guess what that translates to? What I just showed you about treatments. If you're less dependent, the costs are going to be less. All right, so this is a study. So we did that in 2008, 2009, about the same time. And then, by the way, that data was not supported by pharma. It was supported by my NIH grant and our center at Mass General. The Pittsburgh Alzheimer's Center, same thing, did a different kind of study. They said, you know what? What if people take one medicine or two medicines or no medicines? What happens to a very hard endpoint, which is nursing home placement and death? Guess what? If you took several medicines, the chances of you being not in a nursing home was much, much less over years. Again, supporting the fact that what these things are doing is probably giving you support to expand out the middle stages of the disease supportively. This study from Baylor basically showed that if people are persistent in taking the medicines, they don't go on and off, it's worth about 1 to 1.5 points on the mental status exam every year. Okay? And this is from Europe that now shows, and about 10 other studies from Europe show that the rate of Alzheimer's decline is slowing over the last 10 years. Why? Have we cured Alzheimer's disease? No, people are on medicines now. So that's what's happening. They're progressing slower. So that's why actually the European associations for neurology recommended that once you get to the moderate and beyond stages, you should be on 2 medicines. Your reflexes seem fine, Mr. Hart. So, what are the effect sizes for antipsychotics in psychosis or aggression? I taught you about effect sizes. So if someone has psychosis, you give it, the effect size is really large, right? Should be 0.8, right? It's actually about 0.2. So it turns out that, guess what? Some people really, really benefit. Some people don't benefit at all. And when you give antipsychotics, you better have done everything else in between before then. Because when you do give the antipsychotics, cognition goes down. So you lose about a point and a half over 6 months or more. Your risk of death and cardiovascular events go up. Basically, they go up by about 1.5 to 1.7. And the longer you're on them, guess what? The longer you're on them, if it's 3.5 years or more, people who are on placebo versus antipsychotics, the death rate is twice as much. So, it's not a benign treatment. Sometimes you have to give it, but the idea really is that over the short term, maybe, but who depends on the risk-benefit calculus. If someone is immediately in danger, aggressive, psychotic, you've done everything else, there's no delirium, etc., maybe, but it's black box warning. With longer treatment, it's really dodgy. All right, so when do we start and how early? Generally, I usually start with a cholinesterase inhibitor unless there's a contraindication, which is unstable bleeding, GI bleeding, unstable arrhythmia. I don't tell people go with God, take the medicine by yourself, and take it on an empty stomach. Guess what? They'll take it, they'll forget they took it, they take it again, and a third one, and then they end up in the emergency department because they've had diarrhea or they passed out. Given correctly, people tolerate this medicine. Start low and go up slowly. And then you have to have an informed discussion. Ultimately, you add memantine, and sometimes people are very sensitive to these medicines, and you can start memantine first because it actually slows down the gut a little bit, unless they have a poor kidney function. And again, I'll send you these slides. I'm going through really, really quickly. I'm trying to get you an overview. What else? So this is evidence-based opinion, this part, because there are lots of gaps in our knowledge. What do? You reduce stress. Stress takes up, most people's cognition gets worse under stress. If you have dementia or Alzheimer's disease, it gets much, much worse. It's like this thing that sucks up most of your processing power. So you reduce stress. You really monitor alcohol intake. Guess what? They drink alcohol. They forgot to drink a glass. They drink again and drink again. So that's an issue. And I tell you, in Northern California, it's a much bigger issue than in Boston, I think. Sleep is very, very important. Exercise. If I had a pill, I always tell people, if I had a pill that had the benefits of exercise, and I could get you, the brain function, the growth factors, I would give it to you. I don't have that pill. You just have to do the exercise. And so we talk about that a lot. It helps with mood. It helps with sleep. It helps with irritability. Very, very important. If anxiety and depression really exist and they don't respond to behavioral interventions or the combination, because there's evidence for the combination, then you treat it. And I give vitamin E, and in some cases I give a baby aspirin, depending on the risk factors, but I try really not to use an antipsychotic, and I never give benzodiazepines. That's really, really important. What else? You have to be very proactive about these things, which is what? Prevent, detect, and diagnose and treat all these things. Dehydration, sleep problems, pain, constipation. They may not be able to tell you what's going on, but their routine's gone, or they're constipated, they're dehydrated. And those are the things that end up causing people to go on antipsychotics. And fear and psychosis, very, very important. Helping caregivers cope, making a calm environment at home that's very predictable with predictable routines, common sense problem solving. Activities have to be matched to their preferences. You can't overstimulate them, you can't understimulate. That's really, really important. Don't argue and really have to think about driving safety and things like that. So when I say, what are these strategies? I had to learn about these strategies myself with my dad and my aunt. And, stay positive, interact calmly. It really, really, if I come over here, and Mike doesn't understand what I'm saying, but I'm actually really supportive and he can take my visual cues. I'm going to look him in the eye, I'm going to smile, I'm going to be calm. And that's very hard to do when you're stressed. But I, as the care partner, have much more control over what happens, how Mike behaves. And so that's really, really important. So remind yourself, it's not intentional. They're not doing it on purpose. Redirect them to something fun. Redirect them to a trip they took. Or guess what? Oh, they want to vacuum again? Let them vacuum again or sort again. Go slow. Don't give them too much information at once. Don't tell him. I wouldn't tell Baba, hey, Baba, we're going to see Dr. Pingree next week. He'd forget, but he'd be anxious for the whole week for some reason, right? I would just say, hey, Baba, put your jacket on. We're going to go see Dr. Pingree now, okay? And And then never say no. Allow the moment to pass. He doesn't want to go in the shower right now, let the moment pass. Don't argue, don't convince, don't cajole, don't confront, unless it's safety, really safety related. And of course, you have to think about OT, PT is very important, safety at home, advanced planning, and then caring for the caregivers. All right. Expectations and the sweet spot. Dang, where was I going? We're never going to get Superman where he was before, but it turns out everyone has a sweet spot, and I don't know where that sweet spot is. I generally start lower on the medicines and I go up. Generally, people need more of the cholinesterase inhibitors as time goes on. And so when is the right time? That has to be through clinical judgment. When to stop? Well, guess what? I also at one point was the director of a 100-bed inpatient facility at the VA called the GREC. And we had a palliative care philosophy. At the time when people get to the point where there's no reasonable interactions, there's no personhood, everything should be focused on a good death and getting the family to get there, and they shouldn't be on donepezil, memantine, any of the Alzheimer's meds at that point. They shouldn't be on the atorvastatin. Everything should be through really palliation. Before that, though, believe it or not, in nursing home, there have been studies where people's movements and how they actually do functional communication, if they're moving and able to still communicate functionally, they can still be on medications. And it turns out it really is a race against time. So, the sooner you start, actually, in some ways you're going to gain. And the treatment, I don't mean just with meds, the whole, everything together. All right, in the next 5 minutes before we finish, I'm going to talk to you about studies. Primary prevention. Okay, I'm not going to show you a bunch of data. What I can tell you is that there are now some studies started in Finland and about to start here to look at multimodal, and I know you guys are doing it also, to look at the combination of physical exercise, mental exercise, nutrition, sleep, things like that. And what the 2-year data showing from Finland is that you can actually improve processing speed and executive function. And there's a hint at 2 years. This is in normal individuals, normal. There's a hint that it can actually slow down the number of people who go on to have dementia. Is it going to delay it forever? No. But again, think about if you can delay it for a few years, then that's a lot for society. So we talked about taking care of your factors here. There's a fair bit of evidence that suggests that about 30% of dementia, people can actually ward off those stages. They could in some ways delay it by using some of those factors. What about this amyloid in the brain? Guess what? We were in the beginning. I didn't go through the mechanisms, but there's a few different ways. You can actually, with this amyloid in the brain, you can take it out with antibodies, or you could decrease how much is made. And I've been involved with the antibodies for 15 years almost now. And initially, we were giving it to folks, and we were seeing no effects. It turns out the dose was too low. Now we finally have a drug. This one is aducanumab, that actually is like a vacuum. So this is a patient that has gone in, and actually over time, you're taking the stuff out. Are you getting benefits? Finally, we're seeing modest benefits. We found out that if you do it in the moderate stages of Alzheimer's disease, too late. Even in the mild stages, it has to be really in the MCI stages for the most part. So for the first time, this data was presented that as you're taking more amyloid out of the brain, you're actually slowing down the progression of symptoms. So this is a study that, these are studies that are being done now, but they're not the only studies. And one of the things we learned is that people can have little microhemorrhages or little inflammation with these drugs, depending on the ApoE status and also the dose. So we're learning over the last 5 years how to manage those things. So the lessons really were learned that it's ApoE4 depends on the dose, and that we have to go earlier, okay, not in the moderate stages. There are many other targets, so antioxidants, tau agents, anti-inflammatory agents, apoptosis agents, and we have to think about all those. And unfortunately, many of them have failed. And last week in JAMA, I had an article that came out, was this study right here. It was 3 big clinical trials. I spent 7 years on it as the global PI, and it failed. And doesn't mean we haven't learned from it, and we have. But it's been a rough go. So where are we going? We're going to earlier and earlier. We're looking at people who are at risk. So in this case, these are older adults that are cognitively normal but have amyloid in their brain. We're giving them amyloid-lowering drugs now. Okay? In this study, it's in Colombia. These folks actually have the gene. We know that if you're 35 and you have the gene, let's say your father had it at 50, you're gonna progress at 50. So we're trying to give those medicines to them now to see if we can delay those. And then there's a whole bunch of other studies that are looking at people who are at risk or have the genes. There's a couple of studies that are just starting called Generation 1 and Generation 2. They're looking at ApoE4. Remember those risk genes I told you about? Well, if you have 2 of them, if you're over 60, you can go in the Gen 1 study. If you have one of those genes, it's a risk gene. It doesn't mean you're going to get it. It increases your risk. And you're amyloid positive, you can go to the Gen 2 study. And the idea is to give vaccines or antibodies. And I didn't bore you with a whole bunch of this kind of stuff, which is, you know what, this is what we see. We see clinical and behavioral stuff. But ultimately, we have to use our biomarkers along with genetics over time and be really smart about mathematical modeling, which Dr. Schenkel is really a leader, and has been for many, many years in this field, about how we take our data and what we glean out of it. And if we do that, I think we're going to do okay. And you can see, unfortunately, a small brain and the brain is full. So I'm going to wrap up with the conclusion that really diagnosis is ethically supported. It has to be individualized. And it's really multifactorial treatment that really helps you, not just one thing. It's high touch, and that really in the, we've had all these failures, but the fact is that if we delay dementia by 5 years, we'd reduce projected Medicare costs by 50%. And guess what the projections are? That within 10 years, anywhere between 40 to 60% of the Medicare and Medicaid budget is going to be on dementia and Alzheimer's disease. That's incredible. That's going to bankrupt things. And we didn't just wait until symptoms appear in cancer, stroke, HIV, diabetes. And why wait for it until the organ fails in the brain? It just doesn't make sense. That's too late. And I think I always finish with the principles of ethical ethics. If anything I told you today goes against this, as far as above all do no harm, beneficence, non-maleficence, giving people autonomy and justice, that it shouldn't be available to the elite, it should be available to everybody. I think that early diagnosis and multifactorial treatments, as we empower people to go into clinical trials and we advocate for this disease, is really, really important. We don't cure it right now. We can certainly help and console. And over time, we're going to have a bunch of things that we overlay, including prevention trials. And I personally think that the glass is actually more than half full. And we have to have hope. And this was my car in Massachusetts. And in California, it's actually, there's a space between cure and AD. It's also my Gmail, so you can call me or email me. Thank you very much for your attention.